Hello, everybody. This is going to be a talk on DVT and pulmonary embolism, and this is going to be an update to one of the very first lectures that I did a little over 9 years ago now. So it's been a while, and there's been some changes as far as the management goes and the recommendations. And typically the USMLE is not too hard on you as far as knowing the most up-to-date management. They will typically not give you, if there's a new recommendation, they'll typically give you sort of a grace period. But now that it's been so long, I want to make sure that I'm giving you the best information for now as opposed to the best information for 2013. Because by now it is fair game that they will test you on the differences, how the management has changed since then. Okay, so that's why I'm updating here. If you haven't had the opportunity yet, please consider supporting me on Patreon. I got the link below in the description of the video, or you can click on the I button on the upper right-hand corner. As you know, I keep my videos free and subsist, as far as this goes, only on donations. So I appreciate your consideration. All right, let's get to our vignette. We got a 27-year-old female who's coming into the ED complaining of mild chest pain and shortness of breath for the last 6 hours. She first noticed this after going up a flight of stairs in her apartment after returning from her yoga session. She's never had this before. She says that the chest pain is dull and substernal. Typically they'll point, they won't tell you substernal. And it's worsened when she tries to take a deep breath. That is interesting. She denies fever, cough, or sick contact. She doesn't smoke or drink alcohol. She's not on any medications. Vitals, temperature 99.4, blood pressure 121 over 83. She is tachycardic at a heart rate of 110. She's tachypnic, a respiration's 25. Her BMI is normal. Physical exam reveals a well-nourished female in mild distress. Physical exam is unremarkable aside from her tachycardia and some mild bibasilar rales. Extremity exam shows no swelling or tenderness. So what are our impressions here? Well, she's got chest pain, and she's got some respiratory distress. Now, what kind of chest pain is this? It's always important to know the nature of the chest pain because it'll give us some hints as to what's going on. A tearing chest pain we associate with a dissecting aneurysm. A stabbing chest pain we associate with pancreatitis. Well, what kind of chest pain is this? Gets worse when she breathes. It's a pleuritic chest pain. Pleuritic chest pains tend to originate from the lungs. So you're talking things like pulmonary embolism, pleurisy, pneumonia, things like that. So if the chest pain gets worse with breathing, it's often, not always, originating from the lungs. So look for that clue. All right, so what is our differential? Well, of course, pulmonary embolism, anytime you got respiratory distress and chest pain. Anemia. So why anemia? Well, anemia, you're not getting sufficient oxygen to your tissues. So your body is going to understand that as you're not breathing enough. And so in exchange, you're going to increase your respiratory drive and you're going to breathe more. So you'll become tachypnic in that regard. Now, is it going to give you chest pain? Probably not. But it's important to keep on our differential of tachypnea or shortness of breath. Pneumothorax. Well, yeah, you would get shortness of breath. This is probably less likely in this patient since we did hear breath sounds on both sides, but we should keep it in our differential because she's young and young people can get spontaneous pneumothorax. Community-acquired pneumonia, very, very, very common. It will give you a pleuritic type chest pain, but typically you get a fever with that, and oftentimes you'll hear some adventitious lung sounds. We didn't really hear that. Arrhythmia. Well, she's tachycardic, so she could have an arrhythmia going on. Myocardial infarction. Well, you might be thinking, well, no, she's not the right age. But you got those zebras where maybe she's got a familial hypercholesterolemia, or maybe she's got some kind of clotting issue and she had a heart attack. The reason you got to keep this on your differential is because if you miss it, you're going to get sued. So anytime you got a patient with chest pain, you gotta exclude an MI. And then congestive heart failure. Again, not likely, but maybe she had some kind of congenital heart defect. And so just keep it on our differential. Okay, so what are we gonna do? Well, anytime you've got a patient who comes in with shortness of breath, you are always going to put them on oxygen and pulse oximetry. So that needs to be on your orders, on your clinical case scenarios. You're also always going to get an ABG if they are in respiratory distress. And alongside that, you need to get a bicarb, so we'll put that under BMP. And then you need to get a chest x-ray. So those are things you always do in a patient with shortness of breath. Okay, now what about the chest pain? Always. Chest pain, you get EKG, chest x-ray, and enzymes, cardiac enzymes, which is troponin and CKMB. Okay, so that pretty much is everything here. Supplemental oxygen pulse ox, chest x-ray, EKG, enzymes, arterial blood gases, BMP, CBC, and then two things that we do when we suspect pulmonary embolism. We get a D-dimer, and a D-dimer tells us if there's a clot somewhere. And the reason a D-dimer is good is because it's highly sensitive for pulmonary embolism, meaning if they don't have an elevated D-dimer, you can pretty much rule a pulmonary embolism, and a DVT for that matter, out. Now, if it's positive, if it's elevated, it doesn't mean you necessarily have a pulmonary embolism. So it's sensitive, but not specific. And then a BMP. BMP is typically what we get to look for congestive heart failure, but really it's something that will be excreted into the blood anytime the heart is having to work harder than normal. And so when you have an embolus in your pulmonary vasculature, your right heart has to pump harder. And so as a result, with pulmonary embolism, we often see an elevated BNP. So what are the results? Chest x-ray shows bilateral atelectasis. That explains our lung sounds, and small pleural effusions, but no pneumothorax, so we can take that out. EKG shows sinus tach, no ST elevation. Cardiac enzymes are normal, so we can get rid of MI. Arterial blood gases. She's got a pH of 7.48. That means she's alkalotic. So she's got an alkalosis. What kind of alkalosis? Well, her PaCO2 is low, so we know she's got a respiratory alkalosis. Respiratory alkalosis. Now, she's also got an elevated AA gradient. How do we know that? Well, if you know your alveolar gas equation, you can plug all these in, find your P big A CO or P big A O2, and then subtract your P little a O2. I'm not going to go into the alveolar gas equation. You can look that up. It's useful for you to know, though. Her BMP was within normal limits. CBC was within normal limits. D-dimer, elevated. BNP, elevated. Both of those things point to a pulmonary embolism, as well as the respiratory alkalosis, the elevated AA gradient, and the fact that we can eliminate so many of the other things. This now gives us a presumptive diagnosis of pulmonary embolism. And now this is where you're going to get tested. When you got a patient with a presumptive diagnosis of PE, what is the best next step in the management of the patient? The best next step is to confirm the pulmonary embolism, and to confirm pulmonary embolism, the best test is a CT angiogram. Now, I said that's the best test. I did not say that it is the most accurate test. It's the best test because it poses little risk to the patient and it's fairly accurate. The most accurate test is angiography. Now, we don't do angiography because it's very dangerous. 1 in 200 people who get it will die. So we try to avoid that. So a CT angiogram, also known as a spiral CT, is the best next step to confirm the presence of a PE. Now, you may have heard of the VQ scan, which is something that we can also do to confirm a PE, and that's fine, but it's not the best next step because spiral CT is better. Now, when would we do a VQ scan? If there's a contraindication to CT. note that a spiral CT angiogram requires contrast. So if the patient has had an allergic reaction, particularly an anaphylactic reaction to CT contrast in the past, then we can do a VQ scan. Or maybe if the patient is pregnant and we don't want to give that high dose of radiation, then we could do a VQ scan. Lower extremity Doppler would be appropriate in this patient if she had findings consistent with DVT, but because she doesn't, that's not going to be part of our initial management. Echocardiography is going to be needed to assess for right heart strain. And so it's something that would be good to know. She's probably not having right heart strain because she's not having that much in the way of distress, aside from, her mild tachycardia, mild tachypnea. But you're going to want to get an echocardiogram as part of your further management here. Okay, so we get the CT angiogram and the echocardiogram, and the CT angiogram confirms our diagnosis of pulmonary embolism, and our echo is normal. So now when it comes to the treatment of a confirmed pulmonary embolism, what you need to ask yourself is the patient hemodynamically stable or not? If the patient is not hemodynamically stable, what we're going to see here, so signs of an unstable patient, is going to be hypotension despite fluids, severe hypoxia, and note I say here severe, they're blue in the lips and stuff like that, or right heart strain on echo. Okay, so that points to an unstable patient. So if they are hemodynamically stable, then the best initial treatment is direct oral anticoagulation. And that would be like a factor 10 inhibitor or a direct thrombin inhibitor. So a factor 10 inhibitor, they all have XA in them. So that would be like apixaban and rivaroxaban. And then the thrombin inhibitors include dabigatran. So there are multiple, but those are just two. Now, this is a difference from what we used to do. We used to give heparin and then bridge that to warfarin. But now we just do these oral anticoagulants. They're really useful, they're easy, and we can just do one drug and manage this outpatient if they're not severe. So there is one really important instance in which you would not give the DOAC, in which you would still do the low molecular weight heparin, and that is if the patient is pregnant. And remember that pregnancy does increase your risk for DVT and pulmonary embolism because it's a hypercoagulable state. So in that case, you would give low molecular weight heparin. You would not give apixaban or dabigatran. Now, if the patient is hemodynamically unstable, then you do thrombolytics or mechanical clot removal, which is where you would use a catheter to go in and break the clot. Now, there are a lot of contraindications for giving thrombolytics, TPA, and you should be familiar with what they are. I'm not going to go into them, though. So what do we do with this patient? We're going to probably admit her to the tele floor, continue her supplemental oxygen, the direct oral anticoagulants, and then refer her to hematology for hypercoagulation workup. That's going to be really important because let's say she had something like factor V Leiden. She is at risk for future pulmonary embolisms, especially if she goes on oral contraceptives, if she gets pregnant. She's going to want to know this if she ever gets surgery. So it's important for her to know. That's going to be part of the long-term management of this patient. But it's stuff that you will get brownie points for if you include it on your clinical case scenarios. So DVT and pulmonary embolism are significant causes of mortality, 200,000 deaths in the U.S. per year. DVT is the formation of a clot in a deep vein thrombosis. And the risk factors are venous stasis, so if you're on bed rest, if you're post-op, if you're obese, injury to the vessel wall, and hypercoagulability. Remember, hypercoagulability can be acquired or it can be intrinsic. So acquired would be like being on oral contraceptives, being on supplemental estrogen, And then some intrinsic reasons would be if you have factor V Leiden, if you have protein C or protein S deficiency, if you're pregnant. Now, 50 to 70% of DVTs do go on to form pulmonary embolisms. Pulmonary embolism is a clot that's lodged in the pulmonary arterial circulation. The severity varies wildly. So you can have a patient who drops dead with a pulmonary embolism just fulminantly. Or you could have a patient that's completely asymptomatic. Usually they're somewhere in between. They've got some pleuritic chest pain, shortness of breath, not feeling good, difficult to move around. That is typically how PEs present. So we went over the history of DVT. The symptoms of a DVT, you're going to get leg swelling and pain, warmth and edema of the skin. It looks a lot like cellulitis. And so as a matter of fact, if you have a vignette that really, really points to cellulitis and you really just want to jump on it and say, I want to give them Keflex and send them home, don't do that. If you got a patient with cellulitis in their calf, you got to do an ultrasound, because if you send a patient home on Keflex and they actually had a DVT, they're going to be coming in tomorrow with a pulmonary embolism. So as part of the cellulitis workup, and I'm not talking cellulitis of your neck, I'm talking cellulitis of the calf, you need to get an ultrasound. So very, very important. Another sign that you may hear, but it's kind of a dead giveaway, is something called Homan sign. So if you've got a patient with calf swelling and redness, what you can do is you can dorsiflex, forcibly dorsiflex their foot. If that elicits calf pain, that's a positive Homan sign, and that's pretty indicative of a deep vein thrombosis. The lab findings are nonspecific, elevated D-dimer. Best initial test for a suspected DVT is duplex ultrasound over the affected area. And often DVT coincides with manifestations of pulmonary embolism. If the patient has symptoms of pulmonary embolism, the workup for pulmonary embolism takes precedence. DVT will not kill you. Pulmonary embolism will. So if the patient has signs of pulmonary embolism, then your next step is to make the presumptive diagnosis and get the spiral CT. The treatment for DVT is very similar. It's the oral anticoagulants. This is what a DVT looks like. So you can see that one side doesn't look like the other. And this is a little bit less conspicuous, but you can see it looks a lot like cellulitis. So very important that you know that you need to tease those two apart. Now, pulmonary embolism has a lot of the same risk factors, but the symptoms are going to be different. You're going to have pleuritic chest pain, respiratory distress, tachycardia, all the way up to hemoptysis. Lab findings, you're going to have the elevated D-dimer, but because your heart is working extra hard, you're going to have the elevated BNP, respiratory alkalosis with an increased AA gradient. The diagnosis, best initial test is the spiral CT, but the most accurate is the pulmonary angiography. That is the wrong answer on step 3. On step 2, it's only the right answer if they're asking what's the most accurate test. But the best next test, the best test to confirm is the spiral CT. That's what you're going to do. Chest x-ray is sometimes used as the initial test because at the get-go, we're often trying to exclude things like a pneumothorax or pneumonia. So what you'll typically see with pulmonary embolism is not much. If you do see anything, it's going to be atelectasis. So if the spiral CT indicates pulmonary embolism, you start treating immediately with the DOAC. But if they're unstable, remember, then you're going to give TPA or surgery. The cornerstones of treatment you should know are cardiopulmonary support. If they're hypotensive, give them fluids, anticoagulation, or reperfusion if necessary. The treatment, again, you're going to admit them to the hospital, supplemental oxygen, anticoagulants, and then continue the anticoagulants for 6 months, and I would add a heme consult. One more thing, if the patient is older, I think I mentioned this, if the patient is older, you want to consider working them up for potential malignancy. So if they haven't been in for their colonoscopy, get them in for it, because cancer can increase your risk for throwing clots as well. Now, if the patient's hemodynamically unstable, you'll give them thrombolytic agent like TPA, then proceed with treatment as usual. And if anticoagulation itself is contraindicated, then refer them to surgery for pulmonary embolectomy and placement of an IVC filter. So just to recap, DVT and pulmonary embolism often, but do not always coincide. A DVT presents with a warm, swollen erythematous, usually lower extremity, confirmed with duplex ultrasound. Pulmonary embolism often coincides with DVT. It's pleuritic chest pain, it's dyspnea, and you confirm with spiral CT. Hints are an elevated D-dimer, elevated BNP. Should be part of your initial workup when you've got a suspected PE. DVT and hemodynamically stable PE are treated with direct oral anticoagulants. Unstable PE is treated with thrombolytics or surgery. Patients with DVT and PE should eventually be worked up at some point for hypercoagulability disorders, especially if there are a few risk factors present. Now, later on in another talk, I'm going to go into some ancillary material on pulmonary emboli that's not going to come up on your test, but it may be good for you to know for practice. So stay tuned for that.